Okay, so we're going to begin the procedure by having her, she's going to turn to her left. And as I mentioned, we locally anesthetize our entry points, which are here on the lateral aspect of the malar eminence, and then at the angle of the mandible. And so I'm going to start at the angle of the mandible. We use an 18 gauge pilot needle to make the initial point of entry. And again, as I mentioned, it should be painless. As you push, you feel the resistance of the dermis, and then all of a sudden it gives free, and that tells you that you're subdermal. What I like to do is I give just a little twist to the needle, and then a gentle movement in a circular motion, and then we let it sit there. So that allows for the dermis to dilate a bit prior to placing our suture, the 12. I'm gonna start with the 12 suture, 12 cone suture. And these are actually made, as I'd mentioned, they're polyol lactic acid. They're actually manufactured in the US, actually in our neighboring state in Indiana. Even in the European markets, they recognize the quality of US backed and regulated materials. So these are the little cones, and you can see they're little knots. The knots have not been engaged yet, and this is how they come in their pack. The knots are loosely tied, and so to actually engage it before you place it in underneath the dermis, you just give a light pull, and you can see them locking. So the knots lock, and then now the cones are ready to hold their position. And so I typically do this. Dennis is assisting me today, and so he'll take out the little dilator needle, and then you can see the little opening. Go ahead and turn just a little bit more, because I want you to be able to see the opening, which is right here. So you can, and there's a little depth gauge that allows for appropriate level of entry in the subdermal space. So you put it just to the level of that black line. You can see it right there. There's no resistance. And then you turn to about an 80-degree angle, and then you just enter into that sub-Q space. I personally, because I'm a plastic surgeon and I've done a lot of liposuction, I like tenting the skin. I think it's easier to get into the right plane and to avoid puncturing the dermis. And again, it should be painless. How are you doing under there?
Don't feel
good, good. That's beautiful. So you just want to, it should be totally painless, and we're just in that subdermal space. And we want to just move it in that zone. And it should not, I don't force it, I just kind of let it glide through. So it's just a gentle wiggling motion. You doing okay? Good, 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 good. So it's good to have that discussion with our patient. And you can see there's no tenting or puckering of the skin in that track. And that's really, really important. And you want to see, you see the actual finder needle moving like so, but at no point is it actually puckering or creating any indents in the skin itself. And like I said, it just should move effortlessly under the sub-Q space, or in the sub-Q space. So now I've entered the zone where you can see the epi effect working, and my little finder needle is right here, and then I just gently tent the skin, or we can use, which is another nice little trick, you can use the back of a needle cap, and you just put it over the point of exit, and then you just glide it through like that. And so this is the first placement, and then you can see the little cones going into the skin. So we just glide until we get to this knot. The knot really separates the two sets of cones, so we don't have to go any further anterior than what I just did. So now what I'll do is I'll typically pull the suture back out of the way. That actually helps to dilate the little opening and keep the suture out of the way, and then I put the other one, without forcing it, into the same entry point. So again, we have our little depth gauge showing us the level, and then in the same spirit, we want to make sure that we're not tenting or puncturing the dermis. So we want to be in that just that sub-Q plane. And then we're aiming up to our target. Our target in this case is just in the hairline, in the temporal hairline. Dennis, you got the, thank you. And I'm adjusting my positioning a little bit because I want to avoid the vasculature here that I could feel. And so then you can see it just comes through our point here, and you don't want to see any puckering at your entry point. So a little dimple is acceptable, but you don't want to see a major depression there, because then that means that you've caught the undersurface of the dermis, and that means that you may have a long-term pucker that is difficult to treat. So now we've placed our first one, and I like to leave the needles attached, especially for the hairline, because it makes it easier to find them later. And now we're going to go to our next spot on the cheek. Again, using my 18 gauge. I like to tent up the skin a little bit. It just makes it easier to make sure we're in the sub-Q space. This time I'm using an 8-cone suture, so we can see here again, just for the sake of demonstration, the suture with the cones, or 4 sets of cones on each side of the suture. And as you can see, I pull and it locks the knots. It's also a good way to test to make sure the suture is intact and it's not going to break prematurely. And then Dennis is going to help remove our little finder needle. And then we just, again, in that same spirit, going in that sub-Q tunnel. There we go, she's doing great. And then, again, we can see our point of blanching. Use our little cap technique. Like so. Past the cones like that. And hold this suture back, so I've dilated my space. Drop it into the space. Aim back towards the temporal hairline. Tenting up the skin like I mentioned here. So just creating a little tunnel, so that way the patient doesn't have to worry about feeling anything, and at the same time we're avoiding getting into the deep dermis. Okay, so now again I'm going to make sure, so I'm going to tent up the skin. I don't want to see any undue puckering or unnatural kind of deformity. So that tells me that I've got that second suture placed appropriately as well. Okay, so that's the side. So I think for the sake of illustration, I'm going to go ahead and position her right side, and then we'll use that as our guide for what we want to do with the left side. So the way that this works, because it's bidirectional, is the first set of cones I will position the lower part, of the more anterior part, first. And so with gentle traction forward here, so on the suture that's in my hand, and then with an opposing push going back towards the hairline, you can see, and actually the patients can hear, an audible click. And so what I'm doing is I'm literally moving the sub-Q tissue back over the cones. And it's creating our initial lift. So there, I've already started. And I'm going to do the same thing for the cheek. So again, gentle traction forward, and then pushing back. And you can see the tissue clicking over the cones. You see that? So you can see how her cheek has moved up over. So that's without even adjusting our hairline component of the sutures, the effect that we have. So now as I have her look forward, you can see you already begin to have the effect where we're pulling back and effacing her nasolabial and at the same time helping to efface the jowl. So that's before doing any of our more distal suture tightening. Now I'm going to do the second component, which is right here. No, stay right there. You're perfect. Turn just neutral. Great. So you can see what will, there we go. So you can see the cheek beginning to push down over. And in the process, it's pulling up right here. But this is that three-dimensional change that I was talking about, where we're adding projection to the malar eminence. Because of the fact that I'm pushing down to deliver the cones basically over the tissue, it allows for now increased cheek projection right here. So I'm now going to do the jawline one. Just go ahead and you don't have to move. Are you doing okay?
Mm-hmm.
Oh, excellent. And just so you can begin to see. You see how I'm creating, if I wanted to, I can create three-dimensional projection here, but I don't. I don't want this to project too much. So what I do is, you can see I'm letting off, and then simply by pushing a little bit anterior to my entry point here, I can actually adjust for the pulling component here. And so I can unhinge, so to speak, one of the cones so that I'm not over pulling. But especially in older patients or patients who have more laxity, you want to do a slight overcorrection just so that you can anticipate some relapse. I tell patients that the little marks that they have typically are gone within 2 to 4 days. It's really important during the first week or so not to chew really hard or heavy, because that can unhinge as well the little cones. So this I'm happy with at this point. I'm going to go ahead and go to her left side, because I'm going to do my final tuning adjustments once I have the left side set. But I think we already have a nice initial placement, and I'm going to have her look just like this now, and then chin up a little bit. So you can see the initial effect where her cheek is already nicely uplifted, the jawline is straight, whereas if you look at her left side is flatter, the cheek actually appears to be more ptotic, and we see less definition in the jawline by comparison. So this is already, I think, a really nice beginning enhancement, and then we're going to finish with the left side, and we'll do our fine tuning at the very end. You see the effect, how it's been able to help really lift up. It's interesting. She pointed out something that I wasn't even looking at right away, which now I see, is how it actually helped to make her eye look uplifted as well. And that's something that we do see in our other patients as well. So it really is a three-dimensional way of looking at the whole process. And you can see how her cheek actually has more of a high point compared to the opposite side. And there's no filler, it's just her naturally lifting up there. So now that we've finished her right side, at least our preliminary placement, we can really see on the monitor how her face is already pretty dramatically improved on the right side compared to the left in multiple areas. We see that the lower lid cheek interface appears to have improved. The eye actually has more of an uplifted appearance. As I pointed out earlier, her right nasolabial fold and actually right upper lip, the right side of her upper lip, was quite a bit more ptotic than the left, and that actually has even evened out just by the cheek pull compartment. And when we look at the malar eminence, especially laterally, we see that now as we turn from side to side, and we even look at her OG curve, which we can start to see. I'm going to have you just adjust like that. There you go. So you can see the beginning of her curve here, and then turn the other way. and then there, you see the difference. Her curve is much flatter on her left than when we look at her right. So that is three-dimensionally that component that the bidirectional cones delivers, but at the same time helping with the nasolabial. And then as we go down, we see the difference in the jowl. The jowl has more of a conical appearance, or that inverted cone of youth, as compared to on her left side, it's much boxier and it's almost more of a rhomboid shape as compared to a triangle. So I think we've covered a lot of important three-dimensional improvement. And I think it's really, in my opinion, the next wave or frontier of looking at facial aging. It's not just two-dimensional, but it really is three-dimensional. So with that, I'm going to go ahead and start. We'll do the left side. Okay. And turn just a little more to your right. Perfect. So Dennis has already locked the knots for me on this side. So we're going to start with the 12-cone suture, just like we did on the other side. And again, we go down to the level of the depth gauge, change our angle. You feel almost like a little pop that tells you you're in the right plane, and it should just glide along. And don't force. I'd recommend not forcing, but just letting the needle find its way. Tenting sometimes helps. And we just move to our spot, which is right here. And then, actually where the mark is of the local, we can see exactly where our target is. Just hold the skin, so counter traction, pull through until the cones get buried. The last one is there. And slide your head back just a little bit. There you are. Perfect. So holding the suture out of the way helps to dilate the track. And this really is, as I mentioned earlier, it's like a lazy L, so that we kind of more nicely approximate where it is that we're trying to go, which is up and back, especially for the jawline. Doing okay?
Doing great.
Great. And I did a little assessment of her cheek, even though this side was lower and a bit heavier, her nasolabial on the left side. I think I'm going to be able to do it with just one 8-cone suture. So we're going to see how that works. We're prepared to place 2 if we need to. And again, I'm not forcing it, I'm just letting the finder find the way. Now she winced a little bit because, and I felt it at the same time, I went a little bit too shallow, and so it poked against the deep surface of the dermis, and that stimulates sensory nerve feedback. So all I did is I backed up, made sure I was a little deeper, I just lift up on the back end of the needle, and then I just go forward, so that I'm going deeper. It's painless. It feels better. Mm-hmm. Yeah, so she's happier about that. And then, and this really illustrates why it's so important not to anesthetize this track, because otherwise, had I put local along that zone, I would have gone too shallow. I would have created a pucker. I wouldn't have recognized it until much later, and then it's a much harder problem to deal with. So it's a much more important thing to have good sensory feedback there. And so now we just pull back. There we go. Thank you, Dennis. You know what I do when I'm going to change my position because I feel like I can get a better lift by going slightly differently. And that's the beauty of this technique is you can improvise, because I felt like I was coming up a little too sharp. So I actually want to come down a little bit. There we go. Thank you. Yep, doing okay. Mm-hmm. There we go. Good. All right, so we're going to move you back here like that. So now we're going to do the repositioning that I mentioned. You can really see how that just telescopes up. But see, I did it a little too much, so I can just adjust. This is when you go too much, and it's sitting back instead of coming down. There we are. So that looks good. And then this side, we said that cheek was heavier. But you can see, and I can feel the clicking sensation against my thumb, but then it washes up. And I like that a lot, because now I feel like even with the one, I've been able to get a nice effacement. We're getting a nice lift, and that's even without securing the upper portion here. Same thing for our L suture. So here's an example of where I'm being a little bit more aggressive because I felt this side was heavier. So I'm going to accept a little bit of a pucker here because I know that that's going to settle away. That's a little bit of my local effect, but I wanted to have a heavier pull here because the opposite side was already at a preferential position. So here we can look at her straight on, and I like that. I mean, it's much more symmetric. Let's just take a look straight in the camera. And so we can see, even though this side, the left side of her cheek is volumetrically fuller, that looking at her nasolabial and the marionette lines, that we've gotten a more symmetric positioning. And what I can easily do at a later setting is actually add filler to her mid-face on her right side to make that volumetrically the same. But at this point, I think overall that in terms of positioning, I like what we've done. We've helped to create a much more streamlined jawline. We've helped to efface the kind of more rhomboid-like appearance of the jowl, and she has more of a return of an inverted cone of youth. And I like it. Even her lips look more symmetric. Go and smile. Yeah, and that's without even putting Botox in. So Botox or Dysport or Xeomin, I'm going to actually go ahead and place that as well. But her lips even look more symmetric now that we've done our uplifting. So overall, I think it really is where we need to be. We're ready now to commit to the sutures, so it's as easy as just holding and a little bit of traction, use the scissor to push down, and we cut flush to the skin. You want to make sure that you're getting that little bit of traction so that we know all suture is buried. This is off-label because in the US, as opposed to the rest of the world, the recommendation by the FDA, which in my opinion is an old kind of rationale, is to actually use a Prolian suture to anchor these up along the hairline. That, in my opinion, is unnecessary and actually creates the potential for some adverse events that we used to see with the barb sutures. So they're self-locking, self-retaining, and as I'd mentioned, this is the approach that is used in Europe. And there we are. So I've clipped all the points. We can see there's no real issue of a lot of bleeding or bruising or anything else. I typically will ask them not to put any makeup or any other kind of topical cosmeceutical on for the first 24 hours. And basically, from an activity standpoint, we have a one-page list that outlines kind of easy do's and don'ts, but the obvious ones are not chewing on food that is really tough, like the hard old bread or a tough steak, because the mastication kind of activity can work against the suture holding. And other than that, we ask them to sleep on their back and not on their side for the first few days. But other than that, normal levels of activity, going back to work, etc., is perfectly fine. I let them go back to gym activities at 1 week. And other than that, it really is essentially a limited or no downtime kind of procedure. How do you feel?
Feel great.
Excellent, 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 excellent.